You can go
Yes.
live now.
Hello, good afternoon, all doctors. On behalf of Hetero Healthcare, I, Dr. Prashant, welcome you to this webinar on PPH prevention with Carbetocin. Doctors, as you know, at Hetero, we market products in multiple therapy areas, like in gynecology, dermatology, gastroenterology, pulmonology, orthopedics, etc. We have a very strong R&D background, and we try to develop products keeping patient benefit in mind. Doctor, our endeavor is to improve patient compliance so that ultimately we hope to have a better clinical outcome. We have developed NSAID patches, reverse treatment patches to improve patient compliance. Gynecology, obstetrics, and IVF is an important therapy segment for us at Frenza. Apart from conventional oral tablets like Didropal, Milotin, we market products for vaginal health, Feminora, and Pelitra. We have also introduced a vaginal film under my brand name Celora. Recently, we have introduced Carbetocin under the brand name Carbiact for PPH. We know PPH is a potentially life-threatening condition and requires intense management. To speak more about PPH prevention with Carbetocin, we have Dr. Meenu Agarwal with us today. Welcome, madam. Welcome, Dr. Meenu Agarwal. Dr. Meenu Agarwal, as we know, is a renowned gynecologist. She is DNB, DGO, FICOG, and a Bachelor in Reproductive Endoscopic Surgery, European Board certified. Madam is President, Pune Obstetrics and Gynecological Society 2023-24, Chairperson, Imaging Science Committee, FOXY 2018-25, elected board member, International Society of Gynecology and Endoscopy, course director, endoscopic training courses in UAE. Madam has over 12 publications in international journals. Madam has been first author of 4 books and has authored many chapters in other different textbooks. Besides this, Madam has won many awards like India's Greatest Leaders from Asia 1, Icons of Health from Times Group, Inspiring Gynecologist of West India by Health World, Champions of Foxy by Federation of Obstetricians and Gynecologists of India. To speak more about PPH in India and management with Carbetocin, once again, I welcome Dr. Meenu Agarwal. Madam, welcome once again and all yours. Thank you.
Thank you very much, Dr. Prashant, for this nice introduction. And I shall be talking today, welcome everyone over here, and I shall be talking today on this molecule, Carbetocin, okay, for the prevention of PPH. So that is going to be my topic today. And let me just go back to my first slide. Yes, all right, okay, all right. So Carbetocin, the smarter, superior, and safer choice. I think instead of PPH management, we can kind of also write PPH prevention, which is also a kind of management. When we look at the maternal mortality, we know that PPH is the leading cause of maternal mortality all over the world, and about 35% of the maternal deaths are due to PPH. It is 240 per 100,000 live births in some of the developing countries. Fortunately, it has come down. In India, it is about 100, between 95 and 100 in most of the states. We are fortunate to be in Maharashtra, where the PPH, the maternal mortality rate, has come down to approximately around 33 per 100,000 births. So a great effort by the governments, various state governments, for bringing down the PPH, the maternal mortality rate. And the main cause of this remains PPH so far. The incidence of PPH is about 2 to 4% after vaginal delivery and about 6% after cesarean delivery. So what happens if there is a postpartum hemorrhage? Of course, the stay in the hospital goes higher. Patient does receive blood and blood products, high morbidity, high mortality, and the families do get affected, and there are also long-term psychological impact on the affected women. We do get patients who where the families and the couple is keen to have a second child. However, because of some untoward incident in the first pregnancy or because of PPH in the first pregnancy, they are scared to even go for the second pregnancy. So what happens when when there is PPH? Let us look at how you can diagnose PPH as early as once the blood loss is very less, about 500 to 1000 per ml. Very important is to look for the pulse rate of the patient. The first sign for any hemorrhage, whether it is visible, non-visible, post C-section, post vaginal birth, post any surgery, the first thing would be tachycardia. So whenever you are expecting any kind of a blood loss, you know, you're anticipating any kind of a, make sure that the pulse rate is monitored. Well, suppose you have perforated the uterus while doing a simple DNC or DNE. So just keep the patient on pulse ox so that you know the first thing you would know when there will be tachycardia. However, as the blood loss increases, the blood pressure may slightly fall. It could be 120/80 and earlier, and now you are recording say 100/70 or 90/60. So you know that along with the tachycardia. Marked fall in the blood pressure along with tachycardia and oliguria, and patient is more restless, and when if it is severe there is a code blue call that you have to give, and the patient collapses, she is not passing any urine, and the blood pressure is very very low. It could be 60/30, 60/40 sometimes, and the blood loss is a lot. It could be approximately around 3 liters. That means less than half of the blood, more than half of the blood she has already lost. Then there could be abdominal tenderness, and there could be, there are uterus is flabby, abdominal girth is increased, and you can see visible bleeding vaginally. Sometimes in cases of bleeding which is not visible, like you have done an episiotomy and you know the bleeding is happening at the angle of the episiotomy wound, patient may be bleeding a lot, but it is not here. The uterus will be contracted, but the other signs will remain the same. So what we need to look initially, whether there is tachycardia, whether there is, I'm sorry, it should be hypotension, and any other signs of the blood loss. At that point of time, a good examination of the genital tract for lacerations. So don't use small instrument, use a big SIM speculum anteriorly, posteriorly, look at the lateral walls. Most important, look at the paraurethral area. So external urethral meatus around that area, sometimes there can be big spurters which may bleed. Also look at the angle of the episiotomy and any swelling over there, which is important. So you send the blood for hemoglobin, hematocrit, platelet counts, and of course the coagulation studies, because if the patient has bled a lot, then she could be going into DIC, which you have to keep a monitor on. So how sometimes we may not diagnose PPH early. So the key here is to diagnose PPH early, the moment it starts happening. So the vaginal bleeding may be revealed, or sometimes it may be delayed, concealed. And alteration in the pulse and BP may not be checked immediately. So that is why now the Foxy has come out with a very nice, you can if you have a maternity home, you can go for this Manyata certification where your entire staff is trained. You know, this is a birthing training, how to monitor the woman, how to look after the neonate. So all those things, how, because you know the doctors are not there all the time. So the nursing staff should be the first one to pick up any flabby uterus, atonic uterus, high pulse rate, low drop in the blood pressure. Of course, if the bleeding is visible, then it can be recognized much earlier. So what are the complications? Of course, a postpartum depression, because one thing is she's lost so much of blood, and then you are giving blood, and then everybody is running helter-skelter. So all that can cause a bit of psychological depression to the mother, along with the postpartum blues, which can anyway happen. The anterior pituitary ischemia, so there could be failure of lactation. Sometimes she may go amenorrheic, because they go into hypo situation. Anterior pituitary ischemia, so anterior pituitary is not secreting FSH, LH, nothing. So there is no menstruation. So how do we need to treat this patient? Then we need to treat them like hypo, give them estrogen plus progesterone for the bleeding. And when she wants to conceive, sometimes she may require a dose of HMG. And she may be also, of course, because of anemia, fatigued, dilutional coagulopathy, myocardial ischemia, if the bleeding is not stopping in spite of the blood transfusion, and it can even lead to the loss of the patient. So how do we actively manage the third stage of labor? First is that we must give some uterotonic agent for the contraction of the uterus. Second is a delayed clamping of the cord. Wait, if it does not come out on its own, then we can give controlled cord traction. And once the placenta is out, then you must look at the uterine tone and to ensure the contracted uterus. So a large WHO-directed multi-center clinical trial, they have highlighted that we must use uterotonic as the most important active management of third stage of labor. Even FIGO, even the National Society of the Midwifery, they recommend the use of uterotonic as the most important thing in all deliveries as the active management of third stage of labor. So how do we do the prevention of postpartum hemorrhage? We must identify high-risk women. When I say high-risk women, women who've had a previous history of PPH, women with twin pregnancy, with polyhydramnios, with placenta previa, with placenta accreta. So all these women are at high risk of PPH. And then I think all women should deliver in an institute, in a birthing place. Somehow the home delivery concept, though it may be popular in some countries and some places, I always feel that is a little better. The patient should be delivered in a nursing home. A strict vigilance of all women in third stage of labor, and active management of third stage of labor in all birthing women, examination of afterbirths, whether the placenta is complete, total membranes all have come out, it should be a routine. And if there is a difficult delivery, any instrumental delivery, destructive delivery, we no more do it, perform, nobody does it these days. So the uterus, the cervix, the vagina should be explored nicely in cases of these difficult deliveries. So when to give the uterotonic agent? So what all we can use? We can use oxytocin, we can use carbetocin, we can use ergometrine, we can use syntometrine, where 500 microgram of ergometrine with 5 units of oxytocin, and we can use misoprostol. So these are the ways. Now oxytocin can be used even for induction of labor, augmentation of labor, and as a therapy of PPH. Carbetocin is more, what is the indication? Is mainly the prevention of PPH, right? So this is the difference between these two molecules. Ergometrine also prevention of PPH. So Syntometrine, meso can be used for induction, augmentation, and prevention of PPH. So when we give it at the crowning of baby's head, or at the delivery of anterior shoulder, or at the end of second stage. Now, when I was studying in Armed Forces Medical College, we were to give whatever uterotonic we were using at the delivery of anterior shoulder. However, now in private practice, we feel that once the baby is out, at that point of time, it is a good idea to give a uterotonic at that point of time. It would prevent PPH, and this is the active management of third stage of labor. And then is a therapeutic use. When I say management of PPH, then we would go for oxytocin or misoprostol or any other prostaglandin. Now let us look at the different molecules what we can use. Uterotonics, we can use oxytocin, misoprostol, or injectable prostaglandins. This is for treatment of PPH. Okay, and then we can also use tranexamic acid and recombinant activity factor 7A. Though this is expensive, tranexamic acid again can be used routinely for all patients. There are many publications where you can use 1 gram tranexamic acid just before starting the C-section. Then uterine tamponade, and of course surgery remains the last option when you have it is not, patient is not responding to any kind of PPH treatment. Then you may go for anterior artery, internal artery ligation, or you can even go for sometimes for the sutures, or you can go in for the hysterectomy, so post-delivery hysterectomy. Now, what are the challenges? Why, I mean, what is the difference between different molecules? Now, when we say oxytocin, two things. One is that we need to keep it in the refrigerator. Number two, it has a very short half-life. You give it, patient responds to it, but you have to continuously give it. It is not that you can just give oxytocin and stop it. With Syntometrine and with methyl ergometrine, both can cause nausea, vomiting, and they do have a slight risk of elevated blood pressure. Misoprostol we can give, again, the main thing is it is more for the treatment many a times, and also it can cause shivering. Shivering is very common with meso. Nausea, vomiting, of course, can be there, but shivering can be very, very annoying side effect of misoprostol. Now, when we look at WHO recommendations of carbetocin, all right, when we say that WHO recommends use of an effective uterine uterotonic for the prevention of PPH, and these all can be used. And why carbetocin is slightly better than others? Because carbetocin is available at room temperature stable. Now, in all the countries where the countries are warm countries like India, also these countries, they are low resource setting. In some places, the refrigeration may not be possible, or the electricity is not there all the time. So even if it is refrigerated, it is not working because there is no power. So that is the very big advantage of carbetocin. It is stable at room temperature, around 30 degrees centigrades. You don't need cold chain storage, and it is provided as a vial. So you don't have to give a continuous drip. You can use it as a vial, and you can use it as a single dose, or you can dissolve it in 100 ml of normal saline and give it as a the IV drip. So both possibilities are there. So the molecule, when we look at the chemical molecule of carbetocin, it is an analog of oxytocin. Okay, it is very similar when you look at the structure. However, because of the change in this structure of the molecule, it has a prolonged half-life. So you give it now, so the effect will last for a few hours as compared to oxytocin, which has a very short half-life. So that is the advantage of using carbetocin. So a single IV dose of carbetocin, if you use 100 micrograms, administered after the delivery of the baby, it is sufficient to maintain adequate uterine contraction. It prevents uterine atony and excessive bleeding, with efficacy which is comparable to a continuous drip for hours of oxytocin infusion. So this is much better. Now, as I said, longer half-life, that is the most important part of carbetocin as compared to oxytocin. So here you can see the duration of action is 60 minutes, half-life is 40 minutes when we give IV, When we give IM, it is almost 2 hours with half-life of 40 minutes. Oxytocin, the half-life is 3 to 5 minutes. And when we give intramuscular, it may last for half an hour, but again, the half-life is very short. So a single IV injection of carbetocin achieves uterine activity within 2 minutes and lasts approximately 1 hour. So it can increase the rate and force of spontaneous uterine contractions, and that is what we want post delivery, that the more we give single dose, we wait for some time, the uterus is well contracted, we tell the nurse to monitor and we leave. So, and the drip can go out and all of that of oxytocin, then the problem is not there. Another important part with carbetocin is it does not cause water retention. Because there is no water retention, there is less risk of hyponatremia, which is there, especially in patients of PIH, and in some patients, we should keep in mind that oxytocin can have an antidiuretic effect, and it can cause water intoxication, water retention, and it can cause hyponatremia. So, so far there is in the literature, no case of hyponatremia has been reported for the use of carbetocin. So let us look at carbetocin. This is the various trials that we will look at. So first thing we here is a champion trial, that is carbetocin hemorrhage prevention trial, which is the largest clinical trial in the prevention of PPH. And there they almost enrolled 30,000 women across 10 countries, including India. All right, so let us see what are the results. The conclusion was, so, they used oxytocin versus they used carbetocin, and they found that carbetocin was non-inferior to oxytocin for the prevention of blood loss of at least 500 ml or the use of additional uterotonic agent. So you use either oxytocin or carbetocin. The carbetocin was not inferior to oxytocin in any kind of a way. However, it does have a single dose advantage and also the advantage of the keeping it at room temperature. Now here, carbetocin decreases the need for uterotonics versus oxytocin. So the patients who were treated with carbetocin, they had less need for additional uterotonics as compared to those treated with oxytocin, because you still have oxytocin in hand when you use carbetocin. In case patient goes into PPH, you can still use oxytocin. You have 2-3 molecules with you. When you have already used oxytocin, then you are, for the treatment, you are short of one definite molecule post use of any uterotonic for the third stage of labor. Then single dose carbetocin versus continuous infusion of oxytocin. Now, hemodynamic effects of oxytocin and carbetocin were compared, and their efficacy was assessed in terms of blood loss and additional uterotonic needed in C-section. So here 51 patients received carbetocin, 100 microgram IV at delivery, and here 51 patients received 20 units of oxytocin in 1 liter of normal saline. All right, so let us look at what is the impact of blood pressure on blood pressure, any need for additional uterotonic, what was the blood loss and the drop in hemoglobin. So a single injection of carbetocin was found to be more effective than a continuous infusion of oxytocin in preventing PPH. This is in C-section. All right. So they had a greater reduction with blood pressure. More women needed uterotonic agents with oxytocin as compared to with carbetocin, and carbetocin women, they had a better uterine contraction as compared to oxytocin at 2, 12 and 24 hours. So this was an RCT done again, carbetocin versus oxytocin, and 1210 patients and who had at least one risk factor for PPH. It could be a twin patient, it could be placenta previa, polyhydramnios, and here they use single bolus dose of carbetocin, or they used oxytocin 20 international units as 6 hours infusion. And they found that lesser incidence of PPH in carbetocin group as compared to oxytocin group, less blood loss, and less number of patients treated with carbetocin who needed an extra additional uterotonic as compared to those treated with oxytocin. So management with carbetocin is associated with greater reduction of PPH as compared to oxytocin. This was again prospective single center randomized double-blind controlled study, 314 patients in carbetocin group, 310 in oxytocin group, and the primary outcome of blood loss of at least 500 ml within 24 hours postpartum. And you was decreased need for uterine massage and the need of other uterotonics as compared to the oxytocin. So good study in these high-risk patients, this particular study. Again, compared to oxytocin prophylactic treatment with carbetocin after elective C-section. So you are doing an elective C-section, you either use oxytocin or you use carbetocin for the third stage of labor. Carbetocin reduces the need for additional uterotonics by more than 50%. See here, 462 patients, they use carbetocin. Here, about 1,000 patients, they use oxytocin, and they found carbetocin was most effective as compared to oxytocin 5 international unit bolus subgroup. Now, whether to use carbetocin or to use Syntometrine, right? Syntometrine is a combination of oxytocin and methyl ergometrine, and they use 240 women with single pregnancies, healthy single pregnancy, no high risk. They used either carbetocin or Syntometrine as a single dose for intramuscular injection following the vaginal birth. And they found that requirement of additional uterotonic therapy, incidence of PPH, and amount of intrapartum blood loss was assessed after using these two, and they found reduction in postpartum blood loss, smaller drop of hemoglobin, and less adverse effects with carbetocin as compared to Syntometrine. So this was again a good study comparing these two molecules for the third stage of labor. It does have a comparable safety profile like vomiting, nausea, headache, leukocytosis is much less with carbetocin as compared to with oxytocin. Now, carbetocin, again, arrhythmias, palpitations, because there is no water retention. However, whether it can be used for heart disease patients, we need to look at further more studies. But the fall in blood pressure is not there. Skin rashes somehow with oxytocin is much more as compared to with carbetocin. So efficacy of carbetocin was checked against conventional uterotonics agent for the prevention of PPH. So when we compare it with oxytocin, Syntometrine, or placebo after normal delivery or and after C-section as well, and they found that intramuscular administration of carbetocin at a dose of 100 microgram is more effective than oxytocin for the prevention of PPH. Its use is associated with less blood loss, better tolerability profile as compared to Syntometrine. And in women who underwent cesarean deliveries, the risk of PPH is lower in group receiving carbetocin as compared to the group who's receiving oxytocin. and it was found to be more efficacious as compared to Syntometrine in the again in the prevention of postpartum hemorrhage. So whether to use again Misoprostol plus Oxytocin or Carbetocin. So IV Carbetocin demonstrated similar efficacy to sublingual Misoprostol plus Oxytocin infusion. So you give both sublingual Misoprost 200 or per rectal along with Oxytocin infusion. So either you give this or you use intravenous Carbetocin. Now, one thing we have to keep in mind that Carbetocin is primarily for prevention, whereas both Misoprost and Oxytocin can be used for prevention as well as for management. So in my opinion, so you use one drug for the prevention, and only if you need, then you keep others as standby, which you can use for the management in case there is still a PPH in spite of using any uterotonic. So when we look at various countries' guidelines, which have recognized the benefit of Carbetocin for preventing the uterine atony. So you look at WHO, again Carbetocin is one of the drugs advised. Canada Society, Carbetocin only. FIGO is again one of the recommendations for PPH prevention. Germany, FCOG, France, FIGO. So all these are definitely in favor of Carbetocin as one of the recommendation for prevention of PPH. So postpartum hemorrhage remains a clinically significant cause of maternal complications and can plays a huge role in maternal mortality. It is common and it can occur even in women who are not at risk. So that is very, very important statement. So all women who are birthing, whether it is a C-section or a normal delivery, active third stage of labor is very, very important, and that can reduce the risk of PPH by more than 40%. And this also, PPH has a major impact on the lives and health of the patient and the families. So when we talk about Carbetocin, it is synthetic, long-acting. Okay, it's a long-acting analog of Oxytocin, can be used for the prevention of PPH. It is temperature stable. You can keep it at room temperature. So in low resource settings, room temperature, and even in high resource settings, sometimes nurses don't remember to put it inside in the fridge. It is lying outside, or the electricity goes, or the fridge is moved from one place to the other. So it is a good drug to have it by the side of the patient, and it has similar efficacy and safety profile as Oxytocin. It significantly reduces the need of additional interventions and uterine massage, reduces the need for additional uterotonics, and reduces the blood loss to less than 500 in most of the women. And this trial, this champion trial, which I discussed, they found that Carbetocin was not inferior to Oxytocin, especially for the prevention of blood loss of at least 500 ml or less, and compared to Syntometrine and Misoprostol plus Oxytocin, it has better hemoglobin levels and lower risk of hypertension, less adverse effects recommended by WHO, FIGO, SOGC, Canada Society. They recommend the use of Carbetocin in the management of PPH. So today I was discussing on WhatsApp with my, some friends were discussing. So it is for I think Dr. Prashant and the company people are there. So very nicely, I don't even know, because in WhatsApp we have so many doctors. So I would like to add one more practical point. Carbetocin IV during normal delivery reduces the placental expulsion time versus markedly reduced blood loss, with markedly reduced blood loss. So suturing of episiotomy becomes hassle-free. I'm very happy with Carbetocin, and I'm using it exclusively for last 1 year. This is Dr. Subodhini Jetmalani. Then Dr. Rumi Patel says, I have been using Carbetocin since its release in India about 2 years back. Excellent for prevention and treatment of PPH in vaginal delivery or LLCS. As first line treatment as soon as baby is delivered, till now, only about 5% of my patients have required additional uterotonics like methogen or prostaglandins for the prevention of treatment of PPH. Another benefit of carbetocin is that it rarely causes nausea or vomiting compared to methogen or prostaglandins. There were many more, but I just picked up these two. So I think, the change is always initially critical, then it is welcome. So the world does move towards better things and better molecules. So thank you very much. And thank you everyone at Dr. Prashant and everybody there for giving me this chance to speak to the great audience on this particular good molecule. Thank you very much.
Thank you very much, madam. Those questions were lovely, eye-opener, like reducing the placental expulsion time.
Yes, yes.
And there are a few questions here. One is that, of course, we have seen the advantage of oxytocin. Can we globally say oxytocin, is it better than, carbetocin, is it better than oxytocin?
See, now again, as I said, carbetocin
And of
is,
course, why? Yeah.
carbetocin is exclusively for prevention of PPH.
PPH.
Oxytocin you can use even for the treatment. So keep your oxytocin, keep your prostaglandins with you. Use carbetocin for the prevention. Those
Okay.
for therapeutic, if required.
And even for induction second stage also, we can use
Then
oxytocin
augmentation,
and
you
like,
can use
yes.
oxytocin, most definitely, yes.
But can we say globally that carbetocin prophylactic we can use in every delivery to prevent PPH?
You can use it, yes.
Yes. And, it's quite likely that some people use oxytocin and antepartum in the second stage. Such cases, they can straight away use carbetocin in the third stage. You can use.
Yes.
And of course, with people with multiple reasons, there would be some cases of oxytocin failure, maybe because of fatigue, receptor fatigue, etc. What would you ideally suggest? Of course, carbetocin, of course, will not work there. What would you suggest in those patients?
Then I would suggest prostaglandin.
Prostaglandins, because of a different mode of action. Or even over methogen, you would recommend
Prostaglandin would be a better molecule. Methogen causes a lot of nausea and vomiting.
Okay. And how common is this oxytocin fatigue? Does it really happens or only theoretically?
If you have used it for induction of labor, it does happen sometimes.
It does happen sometimes. And how, amongst multiple causes of the uterine atony, which is the most common cause of uterine atony?
I would say maybe twin triplet delivery. That is one of the common causes. Anything which causes hyper distension of the uterus,
including hydroamnios, maybe
polyhydramnios, placenta previa,
placenta previa.
And how would you placenta percreta, all of these?
Yes. How would you manage a PPH in patients with preeclampsia or maybe patients in second trimester of MTP?
See, second trimester MTP, one thing is very, very important. Don't rupture the membranes, number one. Don't pull on the cord, number two. The moment you pull on the cord, it will break and then you will keep on waiting. Just wait, don't do anything. It expels on its own and the whole thing comes NSAC if you don't do anything. The moment you puncture puncture the membranes, moment, then it gets stuck.
Trouble starts. Yeah. Do you really think, madam, that maintaining cold chain is a problem in our countries, especially even in metro cities?
See, I am sitting in Pune, so if I say I have a problem in maintaining cold chain, it is not the right thing for me to say. However, we should not forget that we are not, the entire country is not like one city.
Correct. So and especially in our PHCs, etc., this could be a trouble. Because in the interior, there could be a power.
Yes.
And with all these pluses of carbetocin, like we know that there is no cold storage required, we know that the incidence of adverse effects is less. Efficacy, I say, is more or less similar to oxytocin. Why is it that carbetocin has really not come up to the level of oxytocin in terms of prescription doctor acceptance?
Yeah, because ek to one what you are doing very good initiative to have more and more of these webinars and online class thing.
Yeah.
No, sometimes we
Awareness,
don't want to
awareness
change.
is
We are
required.
using one and we
Yes.
don't want to change unless we actually listen to something which is
Absolute.
no, that is some yeah.
Sharing of experience, or
Yes,
and
yeah.
of course, what works, one doesn't like to change. We have read oxytocin in our textbooks.
Right. Mm.
Is Syntometrine available in India, madam?
Synto used to be available. Now I don't know whether it is still available. Yeah.
People will use them separately, like oxytocin and ergometrine. I think that is all from my side, madam. If there's anything, we'll come back to you.
Surely. No
But
worries.
thank you so much. It was a lovely session. The additional questions were really good eye opener for it. I'm sure many of the people must have benefited out of this. Thank you
Right.
so much once again. Thank you.
Thank you, Prashant. Thank you, Bhavishi. Thank you, Sandhya.
Thank you.
Thank you very much.